Hello, everyone, and welcome to the first webinar for the Child and Adolescent Psychiatry Portal for the 2022 to 2023 academic year. Today, our topic is ADHD and common comorbidities, evaluation and treatment. My name is Joanne Jung, and I'm a pediatrician and the Senior Associate Director for CAP. I help to organize a lot of these CME activities along with my colleague, Lauren Schumacher. And I'm pleased to introduce her and our other speaker for today. So Dr. Lauren Schumacher is an assistant professor of psychiatry at the UCSF Department of Psychiatry and Behavioral Sciences, and she's an attending psychiatrist at the UCSF Hyperactivity, Attention, and Learning Problems Clinic, where she has a variety of clinical, teaching, and supervisory roles. She's also an attending psychiatrist at UCSF Benioff Children's Hospital, Oakland, and one of our consulting psychiatrists for CAP. Where she also assists in organizing continuing medical education activities, including this webinar series. Dr. Lauren Haack is an attending psychologist and associate professor in the UCSF Department of Psychiatry and Behavioral Sciences. She works clinically also in UCSF's HELP program, which focuses on ADHD, as well as in the Wayfront Cognitive Behavioral Therapy Clinic. And at CAP, she helps to provide the Reach Out and Connect, or formerly known as the Second Step Psychological Consults for Families. She also leads our school-based mental health project. Her research interests focus on cultural influences in mental health assessment and treatment and accessible culturally appropriate services for traditionally underserved youth and families. Just as a logistical note, we will be reserving the last 10 minutes of this hour for question and answer period at the end. So if any questions come up for you as you're watching, please type the questions into the Q&A section of Zoom, and I'll be reviewing those and sending them up to our speakers to address at the very end. So with that, thanks so much, Dr. Haack and Schumacher, for speaking on this really important topic, and I'll turn the platform over to you.
Thank you so much, Joanne. So as you heard, today we'll talk about ADHD and common comorbidities. We don't have any disclosures for you. And here you can see what we hope to accomplish today. The comorbidities that we're going to focus on are going to be anxiety, trauma, disruptive behavior disorders, and learning disorders. If we have time, we also hope to touch on some of the less common but still common comorbidities like tics and sleep disorders. If we run out of time, we do have some slides for you on the slide deck that you can access. So we're going to start today with a wait question. So this is, we'd like you all to type your answers in the chat, but wait to hit send until we say go, and then we'll say go and we can kind of see everyone's responses at once and some common trends. So our first question, type your answers in the chat. When you have a youth presenting with attention and behavioral challenges, what other conditions do you commonly consider alongside ADHD? So go ahead and type your thoughts in the chat. And hit send. Great. So we're seeing a lot of trends, and many of these we will be talking about today. So if we look across what are the common conditions, many of them are the ones that you identified in the chat, right? So actually the majority of both boys and girls with ADHD also will meet criteria for another mental health disorder. We tend to see, on the whole, boys are more likely to exhibit externalizing conditions like disruptive behavior disorders. And recent research is showing us that girls with ADHD may be more likely than boys to have comorbid internalizing conditions like anxiety or depression. We also see that about 2/3 of people with ADHD frequently have other conditions like learning disorders, sleep disorders, and tic disorders. So this is not an exhaustive list, what we're going to focus on today, but some of the hardest hitters.
So when you're thinking about evaluating for ADHD, as you guys have probably experienced, you always want to be also thinking about and assessing for co-occurring or differential physical and mental health conditions. And in fact, that's such an important part of ADHD evaluations that it's specifically delineated in the AAP practice guidelines for ADHD. So next, we have another weight question where you'll type your thoughts in the chat and then hit send when we say go. How do you evaluate ADHD and co-occurring differential disorders in your practice? Any favorite tools? Okay, go. Let's see. Yes, I'm seeing Vanderbilt's, clinical interview, review of any IEP testing, DSM-5 criteria. Yeah, those are great, all great options. So unfortunately with ADHD, there's no lab tests, no kind of single test we can use to know for sure they have it or don't. That would make our lives a lot easier, wouldn't it? The gold standard is comprehensive inquiry. So kind of taking a multi-method, multi-informant approach where you're interviewing the patient and parents, getting measures from the parents and teachers and patient, observing what they look like when you see them in clinic, and also potentially considering testing if needed. You want to be thinking about kind of different domains, school, home, social functioning, activities, and make sure to ask about functional problems as well as symptoms. So how they're doing academically in school, are there peer problems, challenges with emotion regulation, family problems, things like that. Things that can be helpful with this evaluation, because it's a lot to cover and keep track of, are using ADHD rating scales. So as a number of you guys identified in the chat, one of the most common and popular ones is Vanderbilt. Nice things about Vanderbilt is there's both parent and teacher rating scales. It's validated for ages 6 to 12, but we frequently also clinically use it kind of at a wider age range as well. And one of the things that's great about the Vanderbilt is, in addition to asking about those core inattentive and hyperactive ADHD symptoms, it also has, in the initial Vanderbilt, has sections that ask about ODD symptoms, conduct, and depression and anxiety. So that can be a great way to both check in on ADHD symptoms and do an initial screen for some of the common comorbidities. The SNAP is another popular one. That one is validated for ages 6 to 18 and asks about inattention, hyperactivity, and also has an ODD scale. And then another good one to use is the adult ADHD self-report scale, which is can be used for ages 13 plus for self-report. So you can have the patient fill that out. And you want to think about completing scales kind of during the assessment, both to help with diagnosis and to give you a baseline. And then kind of every 6 months during treatment or when you're making medication changes. And then in terms of kind of thinking through assessing and screening for comorbidities, I think there's a couple different approaches you can take. One is to use a general screening tool. So thinking about something like the pediatric symptom checklist, the strengths and difficulties questionnaire, and kind of doing those early on and kind of seeing if there's then particular domains that come up that you want to ask more about. You can also really let the clinical interview guide you if you're hearing about attention problems, but also hearing more about anxiety or depression symptoms from parents or the kid, then that might be an indication to do kind of more domain-specific screen like the SCARED or GAD-7 for anxiety or the PHQ-9 for depression. And then also good to think about doing trauma screening, such as the PEARLS. So you're kind of thinking back to that, all the different things that you might see. There's, a number of screenings that if on interview or kind of the maybe Vanderbilt or a general screener, you're having areas of concern, you can then do more detailed screening. And so kind of then thinking about the overall evaluation, patients coming in, presenting with challenges with inattention, you want to first you want to be thinking through are they meeting DSM criteria for ADHD? So looking for those more than 6 symptoms of inattention or hyperactivity that have been present for more than 6 months before age 12, and impairing functioning in multiple domains such as home, school, activities, peers, and aren't better explained by another disorder. So it's important to be thinking about these other disorders both as kind of differential diagnosis or potential comorbidity. So then one more weight question here. What do you do if a patient is meeting diagnostic criteria for ADHD, but it's also scoring high on another rating scale? So go ahead and type your thoughts into the chat, but wait to hit send. All right, go ahead and hit send. Yeah, so this one's definitely a trickier one. I see one answer using the history to see which one came first and how they are related. I think that's a really great place to start, because that can give you a sense of if they were, more, if one thing started first and something else came later, then it might be that the second one is more secondary to the first one. So I think some general principles to keep in mind when you're dealing with ADHD and comorbidities is kind of using your clinical interview, the mental status exam, rating scales to get a sense of if the attention and behavior problems are, best explained by ADHD or might be better explained by a kind of another condition, or are they occurring concurrently? And then kind of as a starting point, generally what we recommend is figuring out which symptoms are most problematic right now and which are the most impairing and treating those first. And then as that piece improves, targeting what's left. And I think it's really helpful to keep in mind that this is an iterative process. With these complicated kiddos that come in and there's, trauma and ADHD-like symptoms and, anxiety symptoms, maybe some mood piece, also sleep disruption. You're not going to be able to sort it all out in one visit. It's going to be kind of over time, observing the patient, getting to know them better and seeing how they respond to different interventions that your understanding of them will evolve, and that's okay. So we're now going to dive into some of the specific comorbidities that come up most frequently. The first one we're going to talk about is ADHD and anxiety. So anxiety is very common in kids with ADHD, with about 12 to 50% of youth with ADHD also having an anxiety disorder. And this one can be a kind of diagnostic tangle, because especially like if you've got a kid, less of the hyperactive piece maybe, but if more inattentive and they're spacing out in class, it can be hard to know, is it more anxiety, or are they having a lot of worried thoughts that are meaning they're not kind of paying attention and present in the classroom? Is it more ADHD, where they're kind of having trouble regulating their attention and getting distracted by extraneous stimuli? Or is it both? So that can definitely be a challenge. In terms of thinking about treatment, when you do think kind of you've got a kid that's dealing with both ADHD and anxiety, for the ADHD piece, you really want to kind of still follow standard ADHD treatment. So kind of thinking about FDA-approved medication, behavioral therapy, and school accommodations. Of note, despite kind of early concerns and an FDA warning regarding stimulants potentially exacerbating anxiety, more recent kind of larger studies have really not found that. So they don't show that stimulants worsen anxiety. And in fact, in some cases can actually decrease it, which makes sense because ADHD is a pretty anxiety provoking experience when, you're missing out on things, not always tuning in when you're supposed to. And, suddenly things are expected of you that you don't know what's going on. That's anxiety provoking. So stimulants are often still helpful. One note is with those particularly somatically anxious kids that experience a lot of their anxiety symptoms as physical symptoms in their bodies, sometimes they can be especially sensitive to stimulants, slight heart rate increases. And another medication to consider if they're having issues with stimulant side effects is atomoxetine, because it's been shown to be helpful for both ADHD and anxiety together. And then kind of if the anxiety is not improving with ADHD treatment alone, and it's looking more like comorbid ADHD and anxiety rather than some anxiety secondary to the experience of having untreated ADHD, then you want to consider treatment with CBT, SSRIs, or both.
So when we look into the therapy realm for young folks who have ADHD and or anxiety, really what's most effective is working with parents and teaching parents strategies to manage the child's symptoms and functioning. So arguably the most effective treatment for young folks with ADHD is parent management training. And really, when we look at the strategies that parent management training focuses on, we can call them the 3 C's, right? We want to increase the clarity of our expectations for what we are wanting this child to do. We also want to increase our consistency in how adults respond to that child across their settings and over time. And we want to really focus on celebration, right? These kids with ADHD are often getting much more negative feedback than positive feedback. And actually, one thing we know about brains in kids with ADHD is they over-perceive negative feedback. So in parent management training, we're really teaching parents to flip that on its head and give 5 positive praise statements, being really specific about the child making steps in the right direction for our clear and consistent expectations to every one redirection. And interestingly, when we look at the MTA study, which is one of the largest studies comparing treatments for kids with ADHD, we saw that kids with comorbid anxiety had even better outcomes from behavioral parent management training than kids with ADHD alone. That might be because kids with anxiety, we do a similar focus where we're really working with the parents, right? So for anxiety, when we work with parents, we talk to them about reducing how much they reassure their child when they're having anxiety, because that actually just sends the message that indeed there's something to be anxious about. And we really want to lessen how much they're accommodating that child, because that's going to reinforce a pattern of avoidance rather than exposing ourselves to situations that we need to do, even if they make us anxious. Right. And then we're going to teach parents how to prompt for and praise and reinforce coping skill use when the child is anxious. So how do you use helpful thinking rather than worry thoughts? How to go ahead and make small steps to go to school, to go to soccer practice, even though it makes you feel uncomfortable. Right. So one question I always get asked is, okay, that's great. We know that parent management training works. We know that cognitive behavioral therapy focused on the parents works for anxiety, but it's really hard to get these resources for a lot of the kids that come into our clinic, right? And fortunately, we've made some pretty good advances in terms of offering some of these tips and resources online so that any parent can kind of take advantage of these strategies. So the UCSF Psychiatry, Resilience and Emotional Wellbeing video series has some really nice video examples that both focus on these ADHD strategies as well as these anxiety strategies. And then the Collaborative Life Skills page also has some nice resources for how to increase the clarity, consistency, and celebration of children who may struggle with attention and behavior. We also have some pretty nice online resources from coming out of University of Maryland. They have a library of short video clips as well as handouts for some of these strategies that really work for anxiety and ADHD. And then there is also some online anxiety treatments. There's a free 1-session program called Project Empower, and where it's teaching the parents those strategies to reduce accommodation and reassurance. And then also Coping Cat, which is a really effective therapy, has an online program that parents can access. So the handouts that you'll get with this webinar with the slides have those links in them so that you can give them directly to families.
Then another common comorbidity that comes up is trauma. So both youth with ADHD have an increased risk for experiencing trauma. And when they do experience trauma, they have an increased risk for developing PTSD from it. And this is another one of those diagnostic tangles because there can be a lot of overlap. So if you're seeing a kid that's having difficulty concentrating in school, easily distracted, doesn't seem to listen, is disorganized, restless, difficulty sleeping, that could potentially be ADHD. It could also potentially be trauma. So I think it's important to be screening for trauma and considering the impact of ACEs on attention and behavior. And then when you have a kid that has both ADHD and trauma, again, you kind of want to be starting with standard ADHD treatment for the ADHD side. So starting stimulant medications. But in those with both ADHD and trauma, it's good. You want to have a lower threshold for adding or switching to an alpha-2 agonist. Because there's some data that alpha-2 agonists may help with some PTSD symptoms, such as hyperarousal, in addition to being helpful with ADHD symptoms.
So in terms of psychosocial treatments for trauma, really what we know works is a combination of parent management strategies, right? Because of those overlap with ADHD-like symptoms of the inattention, the disorganization, the difficulty following instructions. And then also helping the child develop some cognitive behavioral coping strategies when they're feeling overwhelmed or anxious. And then moving on to some sort of reprocessing the trauma narrative, right? We really see that this aspect of treatment helps people take control of the trauma that happened to them and their response rather than being controlled by their negative experience. So trauma-focused CBT is one of our most widely disseminated therapies for trauma in youth. That said, it can still be hard to locate services. So they do have some nice online resources. And Sesame Street actually put out a really nice series that describes trauma and the impact of trauma in a very family-friendly way. So we linked to that for you as well. So now we're going to transition into one of our other most common comorbidities with ADHD, and that's disruptive behavior disorder. And so there's a wide range depending on the study, but anywhere from 1 in 5 to nearly 2 in 3 kids with ADHD is also going to meet criteria for a disruptive behavior disorder, like oppositional defiant disorder, ODD, or conduct disorder. One thing that is important to know and consider is that there's pretty good research out there that a child's background can actually influence how likely they are to be identified with ADHD or a DBD or both. And so Lauren's going to give a little bit more detail about that.
Yeah, so there was a large study that reviewed over 200,000 commercially insured children. And they found that the highest rates of ADHD were in white children and lowest rates with Asian children. And you can see on the graph on the side that other minoritized youth, like Black and Hispanic youth, were also lower than white children. And that this seemed to be reflect an underdiagnosis of ADHD in minoritized youth. Additionally, another study looked at kind of rates of disruptive behavior diagnoses versus ADHD in non-Hispanic white youth versus minoritized youth, and found that the minoritized youth were more likely to receive a disruptive behavior diagnosis and less likely to receive an ADHD diagnosis. So I think these disparities in identification can really affect kind of clinical and educational implications and how their treatments are implemented. So it's important to keep that in mind when you're assessing for ADHD and disruptive behavior disorders. So in kids, what you're just seeing both ADHD and disruptive behavior disorder, such as ODD, the combined treatment of both meds and psychosocial interventions is especially important. So this is a group where you really want to emphasize that kind of meds are important, but meds alone is probably not going to do it. And you really want to take that multimodal approach. So stimulants, guanfacine and atomoxetine all have data to support that they can reduce oppositional behavior in kids with ADHD, with stimulants having the largest effect. So those are good to keep in mind. And then if there's significant aggression despite treatment with stimulants and parent management training behavioral interventions, you could consider adding risperidone for the aggression piece.
So in terms of psychosocial treatments for ADHD and disruptive behavior disorders, you're going to start to hear a consistent theme from me, which is that parent management training is really what's most effective. The reason this is so effective for these kids with comorbid disruptive behavior disorders, or even disruptive behavior disorders alone, actually, is that it addresses the chronic and pervasive nature of inattention and hyperactivity and impulsivity, as well as that functional impairment, right? So we really teach parents to help support children be successful at school, have effective social emotional skills, and also be more successful at home. And so really in parent management training, the families are learning lifelong skills for how to take control, how to provide appropriate structure so that their child can be successful, and in turn, how to improve the parent-child relationship, because these become really strained, particularly when you have those comorbid disruptive behavior disorders. You can imagine how difficult it can be to parent a child who is showing opposition. And we know that these can be effective if they're delivered individually in a group setting, or even some of those self-guided strategies that we linked to earlier. In-person and telehealth also seems to work. And if school clinicians are trained in parent management training, that is a promising new setting for families getting these services. Really, these are the common goals that we're targeting, right? We want to increase how compliant that child is, which can be impacted by attention, hyperactivity, impulsivity, as well as opposition, right? We want to increase how independent they are at doing the things that they need to do every day, right? We're going to provide some scaffolding and some really clear instructions so that they're able to do that. Routines are key. And then we also want to target homework completion. That's often really challenging for kids with these conditions, and relationships with parents and siblings. On the parent side, right, because there is that negative interaction cycle that develops over time with children who are struggling in these areas, we really want to increase the positivity and the warmth in those relationships and the consistency, because really any human is more successful when we have clear and consistent expectations and we know what to expect versus with our behavior, how we do with those expectations. Other kind of important areas that are really helpful that are often targeted in these treatments are stress management and helpful thinking, because again, it's very stressful to parent a child who's experiencing these difficulties, and it can lead us as parents to feel incompetent, unconfident, and hopeless, right? So we also want to target helpful thinking, and that you as a parent have the strategies and the support to be able to help this child succeed. We also want to teach the parents how to really scaffold those skills that their child might be struggling with in terms of their social emotional functioning and their organizational skills. And then as the youth get older, we increasingly work more directly with the youth on how to use coping strategies when they're feeling upset, how to organize themselves in their materials, how to have time management and planning, all of those things. So to transition over to our next really common comorbidity, learning disorders are going to occur in about half of kids with ADHD. And for learning disorders, really the gold standard of evaluating those is a psychoeducational evaluation, right? So to meet technical criteria, what we need to see is the child's grade level functioning is substantially lower than what we would expect given their intellectual ability or their IQ. The rub in this is that those are actually really hard to obtain, increasingly so. So insurance reimbursement is becoming more and more difficult, and schools may or may not accept external evaluations even after a family goes through all the hoops to get them. So oftentimes requesting a school evaluation is the best option in terms of ensuring that the youth is actually going to get accommodation and services in school based on what the evaluation finds. So on the CAP website, we have really nice information about what school evaluations look like, what those services and accommodations tend to be in terms of an IEP or 504 plan. And we also have a sample letter that you can actually help the family fill out and submit to the school, which public schools then by law need to follow up on those evaluation requests from families. It can be really helpful to walk them through those steps though, because it's a pretty overwhelming process with a lot of lingo that not everyone is familiar with. And unfortunately, there just aren't enough resources for every kid who needs them. So sometimes it takes quite a bit of advocacy from parents to get the steps needed. Sorry. So one thing that's important to note is that medications are not going to treat learning disabilities, right? So really the way that learning disabilities are targeted are through psychosocial treatment, classroom management, so that that child's able to get the information they need, as well as other accommodations or services like tutoring to get them up to grade level. As I mentioned in the last slide, we have federal regulation that in theory means any child in the public education system meeting criteria for one of the 14 disability criteria should get accommodations and services. So there is one of those 14 categories is specific learning disability. If children have ADHD, they often are going to qualify for those services under the other health impairment category, or perhaps a comorbid condition like emotional disturbance. So what does a child get if they go through the evaluation process and it does seem like there's evidence that they need some extra support? School services are usually obtained through an IEP, an individualized education plan. So for example, tutoring for learning disabilities is one that is more common. And then oftentimes we'll also see accommodations be put into place. And sometimes those come on a 504 plan and a child might not actually need an IEP, right? So accommodations can include things like a seating arrangement so that they're up at the front of the room and away from distractions, maybe testing accommodations like time and a half in a separate room, maybe work accommodations, like maybe they don't have to do all of the homework problems, they only have to do half of them so that they're still getting the information but aren't getting bogged down in the tediousness. And again, our CAP resource, our CAP website has some nice information about those education and school supports. And then Attitude Magazine, which has an online portal as well, has some nice information. When we look into psychosocial treatment for learning disorders, comorbid with ADHD, we're really thinking about how can we help this child with deficits in executive functioning, right? So the planning, the prioritizing, the breaking tasks down to steps, as well as motivational deficits, right? So for kids who have ADHD, tasks seem much more overwhelming and it can be much harder to start, right? So we want to help them be able to have strategies to organize themselves as well as motivate them. And those might need to come from external sources like parents or teachers. And oftentimes other aspects of ADHD are also contributing to that child having trouble learning in the classroom, right? Like if they're having peer problems, if they're emotionally dysregulated. So we might have to also tackle those areas in order to see a real improvement in academics. So here are some potential goals that we can target. We can talk about study skills and motivation. We might target those behavioral or social skills. And that in turn, hopefully targets academic performance, as well as potentially some extra supports like tutoring. We're, again, the common theme really focused on working with the parents and the teachers. Right, we want to help them with those 3 C's, the clarity, the consistency, and the celebration. One of the best ways to do this in the classroom is something called a daily report card, where we give really clear and achievable expectations for that child every day. The teacher gives feedback to that child multiple times a day, and then the child can earn rewards or privileges at home based on their school performance every day. And so there's some nice resources we have linked to help families and teachers create behavioral plans for the classroom, like a daily report card. Other strategies that teachers can employ in the classroom that really help are proactively cueing the child to pay attention to important information and behave in a way that we expect. We can also use teacher attention to redirect them when they're off task and really specifically label their good behaviors for praise. And then again, we can use those token economy systems like a daily report card, or on the flip side, kind of a very clear system of losing privileges based on certain behaviors.
And then another common comorbidity that comes up are tics. So as you guys know, in the age group where we're most often seeing kids for evaluations for possible ADHD, tics are kind of generally very common. And they're even more common in kids that have ADHD, with about 20% of youth with ADHD having tics. Kind of earlier on, there were some concerns that stimulants might worsen tics, and that led to an FDA warning on stimulant medications. But that being said, more recent, larger studies have shown that stimulants don't worsen tics at a population level. So kind of having tics comorbid to ADHD is not a reason to not use stimulants. You still want to treat stimulants first line. That being said, alpha-2 agonists like clonidine and guanfacine treat both ADHD and tics. So if the tics are particularly problematic or causing functional impairments, then thinking about an alpha-2 agonist to kind of treat both the ADHD and tics, or potentially adding on an alpha-2 agonist to a stimulant are good options. That being said, if you've started a stimulant and a patient does report worsening, patient or family report worsening tics, it can be helpful to start by just observing the tic over time, because the natural course of tics is to fluctuate. So it might be kind of just random fluctuation of the tic. So you want to see if it seems persistently worse on the stimulant, or if it kind of continues to fluctuate. If it does seem persistently worse, you can think about a dose reduction, switching to a different medication, such as a stimulant in another class or an alpha agonist. And then if ADHD symptoms do worsen, if you decrease or go off of the stimulant, then you want to consider retrying the stimulant, because most likely it may have just been a coincidence of kind of the natural fluctuation of the tic happened to coincide with the stimulant medication.
So luckily, we have really effective psychosocial treatments that are shown to reduce tic frequency and severity. CBIT, Comprehensive Behavioral Intervention for Tics, is what I'm referring to. And there actually is an online program that families can go through that's fairly low cost, $150 for the entire 8-week program. So this is something that can be really helpful, particularly as youth with tics get older. It can start to contribute to other difficulties like anxiety or self-esteem issues if they're worried that other people are noticing their tics and it's making them different, and that can actually just make the tics worse, right? Which can make it harder to pay attention in school. So we see, all of these things can really reinforce each other. So something like CBITS can be a really helpful step if families feel ready to tackle that area.
And then the last comorbidity we're going to cover today are ADHD and sleep disorders. Sleep disorders are very common in youth with ADHD, with, depending on the study, an estimate of kind of 23 to 70% of youth having sleep problems. It's important to screen for sleep disorders prior to ADHD treatment, because you want to help be able to distinguish between underlying sleep disorders and problems from side effects. The bears can be a useful screening tool for this. So I feel like often what can happen is, when you're first seeing the family, they're really focused on the ADHD part. That's the part you hear about. Then you might start a stimulant medication. They come back a little bit later and they're telling you about all these issues with falling asleep at night. And at that point, it can be hard to distinguish, is this, difficulties related to sleep starting a stimulant medication, or were they already having difficulties with sleep before that because it's so common with ADHD. So that's always something you want to be thinking about. Additionally, it's helpful to screen for sleep disordered breathing disorders such as sleep apnea. And if you do have concerns for that, you want to evaluate and treat it first, as it can cause ADHD-like symptoms. And there was a study that looked at adenotonsillectomy in kids with sleep disordered breathing, and they actually found improvement in ADHD symptoms after treatment. So with sleep disorders, you really want to think about behavioral interventions and sleep hygiene first. There's good data that behavioral interventions are much more effective for sleep than medication. So really emphasizing that part with families and kids and kind of finding out about what their bedtime routine looks like, working on improving healthy sleep habits, working on sleep hygiene, making sure they kind of have a set routine to help them wind down. Avoiding screens is a huge one. And kind of having that consistent sleeping and waking up time. There's often a lot of behavioral strategies that we can really target with kids and families. That being said, some things to keep in mind in terms of medication. If it does seem pretty convincingly related to the stimulant medication, you might want to think about adjusting the timing, the duration of action or dose of stimulant to see if that helps with sleep. If, on the other hand, it seems like it's actually related to worsening ADHD symptoms as stimulants are wearing off, where they're getting the kind of sudden hyperactivity as the stimulants wearing off in the evening, that makes it hard for them to wind down for bed, could consider adding a small evening dose of a short-acting stimulant. We pretty often use melatonin in kids with ADHD to help with kind of that wind down to sleep. And then you could also think about either switching to or adding an alpha-2 agonist if they're kind of getting a good response from a stimulant during the day, but then having issues with ADHD symptoms at night. And could also consider switching to atomoxetine because that doesn't cause any issues with insomnia. So then just to briefly summarize, when you're presented with a kid that is having issues with attention or behavior problems that are raising concerns for ADHD, keep in mind that comorbidity is the rule rather than the exception. So you always want to be screening for comorbidities and also thinking about them as alternative diagnoses. And then kind of at that point, thinking about which symptoms are the most impairing and trying to target those first. And then kind of doing an iterative process of seeing what kind of symptoms or challenges or functional impairments are left, and then working on treating those. It's helpful to keep in mind that many of the psychosocial treatments for ADHD and comorbid disorders feature similar behavioral and cognitive behavioral principles, including kind of really involving parents and teachers and youth in the treatment, and really keeping in mind those 3 C's of clarity, consistency, and celebration. And in most cases, you can still kind of follow standard ADHD medication treatment and then treat the comorbidities as needed.
Since we have a few minutes before we go into this claiming the CME credit, I'd like to go ahead and see, I know that you had a little bit of bonus content prepared. And I do think that since we have a couple minutes before we can go into the Q&A, why don't we go ahead?
So yeah, and I think we can also have some extra time for questions as well. Oh, sorry, actually. Here. So a couple things to keep in mind just in terms of if you're thinking about medications for ADHD and that in kids that also have comorbidities. While for the most part, as I said, you can still start stimulants to treat ADHD with most comorbidities, there's a couple that you don't want to. So if you've got a kid with ADHD who's also actively manic, actively psychotic, has untreated seizures or untreated eating disorder, you want to refer those to specialty care and have those be stabilized first. None of them are absolute contraindications. So once they are kind of in treatment for those and stable. So if they're seeing neurology and they're on a stable treatment for seizures, if they're weight restored after an eating disorder and making good progress with that, and ADHD is continuing to be a problem for them, you can still think about stimulants at that point, but you want to stabilize those conditions first. And then, I think a common concern that comes up is ADHD and substance use disorders. And those with ADHD are twice the risk of developing a substance use disorder compared to youth without ADHD. A common concern parents often have with starting stimulants is that that's going to somehow give them a substance use disorder or make them addicted to stimulants. And really the data doesn't reflect that. Treatment with stimulants for ADHD does not increase substance use disorders. And there's actually some studies that suggested it might actually decrease their risk of developing a substance use disorder. So it's not, that's something to reassure parents about if that's a concern. And then in patients who are presenting with both ADHD and a substance use disorder, you want to kind of initially address the substance use disorder with ADHD treatment quickly thereafter, because it may help with some of the impulsivity that's potentially leading to the substance use. It's a good idea to do an extended release methylphenidate or amphetamine rather than a short-acting one, because the short-acting ones tend to be more reinforcing and are more likely to be abused. Vyvanse, which is lisdexamfetamine, can be a good choice because that one is actually a prodrug. So it has to go through first pass metabolism. And so it has to be ingested orally and go through first pass metabolism before you get the active medication. You can also think about a non-stimulant like an alpha agonist or Strattera, the atomoxetine. And then you also just want to closely monitor use. So, as you have to anyways with prescribing stimulants, be checking cures, making sure they're not getting refills early, and involving parents as well in monitoring of medication. All right, I think should we stop there and open it up to questions?
Sure, that sounds great. First question will go to you, Dr. Haack. How do you optimize communication and follow up with the school?
That's a great question. The absolute first thing to do is to get a release of information between your office and the school so that you're legally able to talk to one another. Sometimes schools won't ask you for this, but sometimes they will. So you want to make sure you have that. Oftentimes it's most helpful to have someone broker that communication. So this is most often the parents, right? So really teaching the parents how to convey to the school information that you may obtain in your office, how to get information from the school to you in your office that you may need. If this is too challenging for the family, they might benefit from the help of someone like a therapist or a social worker to really help be that broker between the two settings.
Wonderful. Thank you so much. Next question. What is your input on melatonin use for treatment of sleep disorders in hyperactive kids? And maybe that's for you, Dr. Schumacher.
Yeah, so I would say, I think there's in terms of kind of longer term use generally for kids with sleep problems, there's still not a lot of great evidence. I think there's a little bit more in terms of specifically kids with ADHD. I think it can be helpful. I certainly always want to, emphasize the importance of the behavioral piece first, and that kind of melatonin alone is not going to be a magic solution for that, and that it's really kind of focusing on the behavioral piece and then kind of can add in melatonin if needed. But I do have patients where it can be really helpful, especially just with that, kids with ADHD sometimes just really have a lot of trouble winding down at nighttime.
Fantastic. Thanks so much. Another question here. One of our participants would like some help differentiating ADHD and bipolar disorder. And that could be either one of you. Who wants to take this first?
Yeah, Lauren, do you want to start or would you like me to try to start?
You go ahead and I can always add in.
So bipolar disorder, if you're really doing a thorough assessment for bipolar disorder, which might be challenging in the primary care setting, if you have real concerns about bipolar disorder, I might recommend making a referral to specialty mental health evaluation, because there is a risk, as Dr. Schumacher talked about starting medication if there's active mania. So that's my initial thought, which I realize might not be a very satisfying answer. So I don't know, Lauren, if you have other suggestions.
Yeah, I think one thing that can be helpful is, ADHD is very much kind of more chronic and persistent symptoms. So kind of if you think back to the criteria, you're looking for symptoms that are present before 12 years old and that have been present at least consistently 6 months. So that's a very different picture than bipolar is very episodic. There's periods of kind of euthymic normal mood. There's periods of depressed mood, periods of elevated mood. And generally, that's not something that's really presenting before 12 years old. So if this is something that's been kind of going on consistently for a long time, since before 12, that would point me more towards ADHD. If this is something that's been more episodic or is newer, coming up more in kind of the teenage or 20s, then I think that would, make me more concerned about kind of a mood disorder piece.
Fantastic. And I also want to point out there will be an upcoming webinar that addresses bipolar disorder and recognition of that, as well as more serious emotional illness. That'll be coming up early in 2023. So be on the lookout for that as well. Another question. This is from a participant who is, will often see ADHD-like symptoms in children who have expressive and receptive language disorders or learning disorders or other processing disorders, and is a little bit hesitant to make a diagnosis of ADHD if these things are possibly in the differential, unless they first have a psychoeducational evaluation or neuropsychological evaluation. And as has been earlier pointed out today, those are very hard to get. So any tips on how to handle like an ADHD diagnosis when things like learning disability, speech delay, processing problems are on the differential and you can't really get an IEP, at least in a timely way?
Briefly, I would say you might consider making a provisional ADHD diagnosis just so that it's documented and you start to kind of raise people's awareness of looking for the presentation of attention and behavioral symptoms in this child as they're hopefully getting some sort of support for the learning disorder or the other processing disorder. If you're really seeing that the attention problems persist even after they're getting support like tutoring, then it might be time to revisit and reevaluate for ADHD and start treating those symptoms if they're continuing to be impairing. I don't know, Dr. Schumacher, if you have other thoughts.
Yeah, I agree with that. I think it also can be helpful with the learning disorders piece. It tends to be more kind of specific domains. So if you're hearing, now obviously can be an oversimplification for some of our kids, but if it's kind of they're doing great in math and science, but really particularly struggling with reading and writing, or if it's, they're doing great in their humanities, but it's like math is, so if there's that more kind of academic domain specific, that kind of might point you more towards, let's pursue the learning disorder piece first. Because ADHD, that functional, that attention impairment, attention affects everything. So, we would less so expect to see big discrepancies between like different subject matters if it's more ADHD. That being said, if they have both ADHD where they're having challenges across the board, but then they may also have a learning disorder where there's that specific area of extra challenge as well, it can sometimes be hard to sort out. I also think it can be helpful to look at kind of how specific the symptoms are to like school learning environments versus, with ADHD, we expect to see challenges at school, but also at home. They're the kid that's on the soccer field and is like in the grass picking flowers instead of, following the ball. So kind of thinking about that, like the multiple domains that are impacted.
Okay, just to cut as a little bit of a follow-up to that question, when you're suspecting that these might be comorbid, that there's ADHD type symptoms that, like, say, affect sports and not just learning, but you're also suspecting, like, hey, really specific, like particularly struggling with reading and everything that touches reading, for example, right? Is it worth, like, even as Dr. Haack had mentioned, making that provisional ADHD diagnosis, treating, and then, like, even while you're waiting for the psycho ed, like what do you think a primary care doctor should feel comfortable doing?
Yeah, so I would say if you feel like there's enough there that it is supportive of an ADHD diagnosis, it's definitely worthwhile diagnosing that and starting to treat that while they're kind of going additional evaluation or testing for learning disorders. And I think one thing to keep in mind is that while medications don't treat learning disorders themselves, if you have ADHD and it's hard to pay attention, then we know that attention it's more attention regulation than just like a deficit of attention, despite the name. So I think all the time parents talk about, like, they can't have ADHD. They pay attention amazingly to video games or things they love. It's only hard things that they have trouble paying attention to, but that's part of ADHD. That's not a volitional thing. So we would, if things are extra challenging for them, then that attention piece it's going to be even harder for them to maintain attention. So treating the ADHD with stimulants and helping kind of their global attention will help with their learning as well. It just won't be enough to also address a learning disorder. They'll also need kind of particular tutoring or strategies that specifically address that learning deficit.
Okay, well, that's wonderful. And I think that there's probably a role for, like, community nonprofits that do special education advocacy, such as CASE in San Francisco. If you feel like there really needs to be this kind of assessment, child isn't getting it, get the advocates involved. Another question regarding assessment of ADHD in older adolescents and youth. Is adult self-assessment alone sufficient to make a diagnosis, or would you also recommend parental input through the Vanderbilts to evaluate for childhood symptoms?
I think anytime you can get some sort of evidence besides self-report, it's better. So can they even bring in report cards kind of showing those things that Dr. Schumacher was talking about? Can you get parent report? That's ideal, but I'll pass it to Dr. Schumacher to say what you think.
Yeah, I agree. I think it's really helpful to get kind of input from somebody else as well. So getting parent input or teacher input, or even if somebody's like no longer in the school system, if they have, if they have a partner or, a coworker who could provide some input on what they're noticing, can be helpful too.
Fantastic. And with that, we are at time. Thank you so much, Dr. Schumacher and Haack, for this great talk today. Thanks for everyone who came in to participate today. Stay tuned. A month from now, we'll be having our next talk on August 11th on depression diagnosis and treatment, and hope to see you then. We will have recordings. We'll have the recording from this talk available on the CAP website within about a week, along with a PDF of the slides for your reference. Take care.